thanks very much for having me here for hosting this. The hard act to follow, Dr. Jared. I will try and move from one end of the spectrum, which is children and adults, to the other end. We're going towards elderly. And as you can see, some of my research interests are in engaging elderly persons with tablet computers, basically, what we're talking about, hybrid face robots. So how much do people with dementia engage with activities and things like that? Anyway, I'm not going to talk about that today. So I'm just going to focus on dementia in family practice. I'm going to give a very brief overview of what is happening and what can be done. So the role of family physician in looking after someone with dementia is huge. I think family physicians are the first point of contact for many persons with dementia, but often they need to have appropriate reference from that point onwards, and also keep continuing to manage these persons as they come to them for various physical ailments as it happens over the period of time. So managing comorbid conditions that they may have, managing any new and emerging problems or conditions or issues that they may face. Appropriate signposting need not be only medical reference, you're also referring to, where do you get diapers? Where do you get diapers that are cheap? Where can I get a caregiver to come and help support this person at home? Where can I get a 24/7 nurse to come and look after my father with dementia and things like that? And then, of course, the end of life care, which is very, very important. I see this as a big issue which many families struggle to cope with, and then supporting the caregivers who are the mainstay of providing care for someone with dementia. So the word dementia as memory loss. I think most of us associate memory loss with dementia. Now, why do we forget? We forget for a variety of reasons. All of us have forgotten something at some point in time. So does it mean we all have dementia? Probably not. Hopefully not. So there are many reasons why we forget. First is being distracted. Yeah, kind of thinking of something, or you don't want to know, especially your wife tells me something, I don't want to know that. I will definitely forget that. Or when I'm in a hurry, I don't like what I'm listening to. I don't want to remember that. Or there are too many things to remember. The child doesn't want to remember. The doctor told me not to use cell phone. So conveniently we forget what we don't want to remember. Or there are too many things to remember. We forget them. Then day-to-day stress. All of us are facing day-to-day stress, and that kind of interferes with how we process information, how much attention we are paying to an information that's being provided to us, and that kind of causes forgetfulness. And then there are pathological reasons for forgetting, and common things are depression, anxiety, substance use disorders, which are very, very common and often missed when we're dealing with someone with memory problems. And then we have conditions like mild cognitive impairment. Those are degenerative conditions we're talking about here, and dementias. So what is dementia? Dementia, memory impairment, as I said, or forgetfulness, is the most recognized symptom. Often reported symptom, probably not, but it's a recognized symptom. But dementia is more than just forgetting. So what I tend to do is to compare dementia with congestive cardiac failure. So dementia is chronic brain failure, okay, similar to congestive cardiac failure, chronic heart failure. And it manifests as a syndrome with cognitive impairment, functional impairment. Like how congestive cardiac failure manifests as, depending on which part is involved, you have breathlessness, feeling, general edema, things like that. So you have cognitive impairment and functional impairment, which are the features of dementia. So when does forgetting become dementia? So memory impairment is at a significant level. It's not your day-to-day routine, forgetfulness that we all experience. It's memory impairment at a significant level. எல்லா நேரமும் மறந்து போயிடுறாங்க. சொன்னது ஒண்ணுமே ஞாபகம் வச்சுக்க முடியல. அடிக்கடி மறந்து போறாங்க. சாவி 10 வாட்டி தொலைச்சிட்டாங்க இந்த last 1 month. Okay, it's happening more often than what is normal. Okay, and there are other brain functions which we will see in a minute, in addition to memory, which are being affected. Okay, brain involved memory. There are also other cognitive functions which are important, and they will be impaired. And the person is unable to perform activities of daily life, the things that they were doing every day before. Now they are not able to do that now. Now that is an important aspect of dementia. So these are various domains of cognition. We are talking about learning and memory, which is highlighted often. But in addition, there are also other functions such as language, which sometimes in fact, you'll find that more in some types of dementia, language being impaired more than memory. And then you also have things like social cognition. In fact, day before yesterday, I saw a patient who had very poor social cognition. When I talk about social cognition, about how you interact in a group, how do you interact with another person in a social situation, and how do you, when she goes to a wedding, she says, ஏன் இந்த பொண்ணு இவ்வளவு கருப்பா இருக்கு, இந்த பொண்ணுக்கு எப்படி கல்யாணம் பண்ணி வச்சிருக்காங்க, நல்ல மாப்பிள்ளையா பாத்துக்கலாமே. So things like that. So you have people who lose their social skills and they kind of utter things which is out of character for them. They wouldn't have done that before. வழக்கமா பண்ணிட்டு இருக்காங்க, that is different. But I'm talking about emerging new symptoms. Okay, முன்ன நல்லா இருந்தாங்க, இப்போ இந்த மாதிரி ஆயிட்டாங்க. So that's kind of social cognition and complex attention. Another thing which we talk about is TV பார்த்து சாப்பிடாதீங்கன்னு சொல்லுவாங்க, நிறைய பேர் பண்றாங்க. Okay, now some other features you will find in dementia is TV போட்டா டிவியே தான் பார்த்துட்டு இருக்காங்க, சாப்பிட மாட்டேங்கிறாங்க, which is a new symptom as you will see. That gives us a clue the person may have dementia. It's about complex attention. When you have complex attention, you're dividing your attention. You're looking at the TV but also eating. Okay, a person with dementia will not be able to do that. They can either focus on the TV or eat. TV is better than eating sometimes, so they watch the TV more. Okay, when there are different things going on, they are not able to focus their attention on different things. That's complex attention. And then executive functions are things like which include multiple brain functions coming together to sequence, organize, plan, and conduct your day-to-day activities. Say, for example, you know that you had a meeting today this afternoon, so you knew this morning இத்தனை மணிக்கு நான் இந்த ட்ரெஸ் நான் போட்டுட்டு போகணும், இப்படி நான் I'm going to drive, I'm going to take an auto, I'm going to take a taxi, whatever I'm going to do. So you kind of plan your day to kind of achieve an objective, which people with dementia will not be able to do. So that is the various cognitive domains which are impaired in someone with dementia. Now, not all of them will be impaired to the same extent, depending on the type of dementia, depending on the area of brain which are impaired. You will see different brain functions being affected to a different extent. But what happens is that in the end, it's a final common pathway, everything comes together. Ella area globally affected towards the end of as the illness progresses. So how to identify dementia? There will be subjective reports. So the person themselves may come to you and say that I have a problem remembering, I have a problem finding right words. முன்னாடி நான் சுடோக்கு நல்லா போட்டுட்டு இருப்பேன், என்னால பண்ண முடியல. முன்னாடி cross words ரொம்ப ஈஸியா இருக்கும், நான் finding it very difficult to do. Okay, that happens to some extent, but to a large extent is the family members who notice this person is not doing as well as they were before. Okay, they're having problems, they're forgetting things, they are being a little bit difficult to handle at times. So those are the kind of reports that the other family members will come to us with. Now, there can be what you need to do in those circumstances to assess that there is a cognitive impairment. And then you do a clinical assessment, and then you investigate to rule out other conditions which we will see in a bit. And then look at various possible differential diagnoses. So the differential diagnoses are these. So this is just a small list. It's a big list of things, but these are the common things which we need to consider and rule out. Of these, the commonest thing which we should be very, very important, we should kind of consider is depression, anxiety, substance use disorders. And then looking at particularly hospitalized elderly people, they are being very confused, agitated. Look at delirium. And then of course, you might know problems. How good is their diabetes? Or do they have a thyroid problem which is undiagnosed or not managed properly? This happens commonly because it's not just that these things are causing dementia. What happens is these things complicate dementia. When someone has dementia, they also have diabetes. They forget to take their medicines regularly. So, or they may overdose themselves on insulin at the month. So that happens. They get frequent episodes of hypoglycemia. You see someone with repeated, unexplained, this person is having repeated complications in managing the diabetes, managing their hypertension or their heart disease. You may want to consider the possibility of them having a dementia, which is being kind of in the background, mild stage, and it's kind of complicating their day-to-day management of their current physical problems. So those things can happen. So how to screen for dementia in a busy clinic? I think many of us find this as a problem, isn't it? When you have only 10 minutes to speak to a patient and do an assessment, how do you screen for dementia? As I said, there is subjective for a caregiver report. இந்த ப்ராப்ளம் இருக்கு, எனக்கு வந்து காக்னிட்டிவ் டொமைன்ல ஏதாவது ப்ராப்ளம் இருக்குன்னு அவங்க சொல்லணும். As such, in mild stages, it's very difficult to capture that in casual conversation. A short 5-10 minute conversation, it will be very difficult. People with, especially with mild dementias, and people who have high intelligence, okay, they very well, they will hide it. They can hide it. It's not that they intentionally hide it, but their overall intelligence comes to their rescue and they will be able to manage. Okay, நீங்க பேச்ச மாத்தினோம், நீங்க அவங்க கிட்ட போன வாரமே நீங்க வரணும்னு சொன்னீங்களே, போன வாரம் நம்ம பேசணுமே அப்படின்னா அவங்க தெரியும், they are forgetting to, they will just change the topic in a nice way that you will forget. Okay, so that happens a lot in early stage of dementia. In a casual conversation, it's very difficult to pick up. Okay, so ask simple questions about எப்படி வந்தீங்க நீங்க வீட்டுல இருந்து. ஓகே, காலையில என்ன சாப்பிட்டீங்க, மத்தியானம் என்ன சாப்பிட்டீங்க. Okay, these simple questions and corroborate that with your, with the relative. அவங்க சாப்பிட்டது நம்ம மட்டும் தான் வந்து கஷ்டம் கண்டுபிடிக்கிறது. But if there is an informant available, corroborate that information with them. Okay, 9 out of 10 times this will be adequate to make you suspect that this person may have a problem. They're not saying it correctly. Okay, in mild stages, these are the issues. Then the question you may want to ask the person or the relative is to say, போன வருஷம் இந்த நேரம் அவங்க பண்றாங்களா. Things like in early dementia, what happens is the more complex activities are impacted. The basic activities நல்லாவே இருக்கும், குளிக்கிறது, சாப்பிடுறது, பாத்ரூம் போறது, அதெல்லாம் நல்லா பண்ணிடுவாங்க. They'll be well grouped and all that. But the more complex activities like going to a bank and withdrawing money, going to some place, கோயிலுக்கு போயிட்டு அவங்க தனியா போயிட்டு திரும்பி வர, சொந்தக்காரங்க வீட்டுக்கு தனியா போயிட்டு திரும்பி வர, those kind of things, shopping, okay, paying money. வீட்டுல வந்து வேலைக்கு ஆள் வச்சிருப்பாங்க, சம்பளம் கரெக்டா கொடுக்குறாங்களா, what happens, கொடுத்தது திருப்பி கொடுத்துட்டு இருப்பாங்க. Okay, this happens a lot. People take advantage of them. Okay, so those kind of things are things which we need to ask them. போன வருஷத்துக்கு இந்த வருஷம் அவங்க போன வருஷம் பண்ண வேலையெல்லாம் இப்பயும் அவங்க ஒழுங்கா பண்ணிட்டு இருக்காங்க, எப்பயும் போல. Okay, and then assess their use of words, ease of recall, உங்களோட general feel when you're talking to them. And then still you have doubt, you can use a screening tool for a cognitive assessment. I'll come to that. There are lots of screening tools, but something which is easy and simple to use, we'll talk about that. So in the moderate stage of dementia, how do you do it? Again, there will be a subjective report, but or a report from a caregiver. But what kind of highlights here is there will be more of behavioral problems and psychological symptoms in dementia, which will be highlighted by the caregivers. சரியா தூங்க மாட்டேங்கிறாங்க, பகல்லாம் தூங்கிட்டு நைட்ல எழுந்துட்டு காலையில எழுந்து 2 மணிக்கு 3 மணிக்கு எழுந்து நான் வந்து கிளம்பணும், ஆஃபீஸ் போகணும்னு சொல்றாங்க. ஓகே, those will be the kind of symptoms. யாரோ வந்திருக்காங்க, கதவு திறக்கணும் 2 மணிக்கு சொல்றாங்க. ஓகே, அவங்க ரிட்டையர் ஆகி 4 வருஷம் ஆச்சு, இப்பயும் வந்து வேலைக்கு போகணும்னு சொல்றாங்க. Okay, those kind of things might happen. You will start seeing that in the moderate stages of the illness, and usually you will find that you'll be able to capture this in a casual conversation. You speak to them for 10 minutes, you'll be able to identify this person has a problem. Things like you ask them a question and they will not be able to answer. They will ask the head turning. It's a very identified symptom. They will காலையில என்ன சாப்பிட்டீங்க, look at that caregiver, என்ன சாப்பிட்டேன் நீ சொல்லு அப்படின்னா, இவங்க யாரு கூட வந்திருக்கிறது யாரும் கேட்டீங்கன்னா அகைன் நீ சொல்லு, அதை கேட்கறாங்க நீ சொல்லு அப்படிமா. They will forget. Okay, they won't remember their names, they won't remember who they are. அதான் கேட்கறாங்கல்ல, டாக்டர் கேட்கறாங்கல்ல, சொல்லு, ஏன் சொல்ல மாட்டேங்கிறாங்க, அவங்க திட்டுவாங்க. Okay, that will kind of give you a clue that there's something is wrong with this particular person. Okay, again, ask them, are they still doing things they were doing before? Cooking, washing, and things like that. But what you see in the moderate stages are that you will see that things, the higher kind of functioning is definitely impact, and you'll also start seeing some minor kind of basic things like bathing. சரியா குளிக்க மாட்டேங்கிறாங்க, பாத்ரூம்ல போயிட்டு பழைய சட்டை பேண்டை போட்டு வந்துடுறாங்க, அழுக்க குளிச்சுட்டு வரேங்கிறாங்க, தண்ணி பாத்ரூம் காஞ்சே கிடக்கு, தண்ணியை ஊத்திக்கலாங்க. Okay, those kind of things. டாய்லெட் போயிட்டு ஃப்ளஷ் பண்ண மாட்டேங்கிறாங்க. Okay, you will start seeing these kind of symptoms. And then assess the use of words. அவங்க பேசும்போது என்னெல்லாம் வார்த்தைகள் யூஸ் பண்றாங்க, ரொம்ப நேரம் டைம் எடுத்துப்பாங்க சில ரெஸ்பான்சஸ். All this will give you a clue. Again, use the screening tool, which will come to it. So severe stage, it's kind of born to dementia, you can't miss it, but often the problem is behavioral symptoms. அதுக்காக வருவாங்க, ஆஃபன் தூங்க மாட்டேங்கிறாங்க, அஜிடேட்டடா இருக்காங்க, கத்துறாங்க, செக்ஷுவலி டிஸ்இன்ஹிபிட்டடா இருக்காங்க, சோஷியல் அப்ரோப்ரியேட்னஸ் இல்ல, துணி இல்லாம வாசல் வந்து நிற்கிறாங்க, தோஸ் கைண்ட் ஆஃப் திங்ஸ். ஓகே, ஆப்வியஸ் காக்னிட்டிவ் இன்ஃபார்மேஷன். உங்கள்கிட்ட பேச ஆரம்பிச்சாலே வாயை திறக்க மாட்டேன், நிறைய பேர் வார்த்தையே வராது, வார்த்தை சொல்றது நாட் மீனிங்ஃபுல் அண்ட் திங்ஸ் லைக் தட். ஆனா they also need help with very basic activities. குளிக்கிறதுக்கு அவங்க பாத்ரூம் போயிட்டு கழுவிக்க மாட்டேங்கிறாங்க, நம்ம தான் உங்களை பாத்ரூம் எங்க இருக்குன்னே காமிக்க வேண்டியது, கண்ட இடத்துல யூரின் போயிடுறாங்க. those will be the common symptoms. But they also have associated physical symptoms like aspiration pneumonia, falls, pressure sores and things like that, which you need to look for. Specifically, we may miss it unless we look for those things. So what are the screening tools that you can use in your clinic for looking for dementia? When you're looking, there are lots of things which are available. Now, many of you who can play with MFC and OCA. Now, Window Screening Instrument for Dementia is a very good tool. Takes about 10 minutes. It's available in Tamil. It's validated in India, so we can use it. But otherwise, simple is Minicog. It hardly takes 3 minutes to do. Okay, she'll go through in a minute. Right now. So there are various versions you can use. We start with this again. When we talk about MFC, we talk about ball, hand, okay, and narcotic, you can use 3 unrelated words. Don't use related words. Okay, 3 unrelated words. Sometimes it happens. You have to see, then you forget. Okay, patient correct so we need to make sure that we remember it correctly. But when you're looking at many things, we forget, as I said, distractibility and too many things to remember. So you and then you kind of give this 3 first patient on only give these 3 words. I'm going to ask you to remember. I'm going to say 3 words. I want you to repeat after me. You say these 3 words. Then you ask them to draw a clock, which again I will show. And then clock ask them to move on to that's all. Okay. So this need not be done by you as a doctor. It can be done if you have a waiting area, and you have a nurse, you have someone. Of course, you need to train them to do this a little bit. They can do it. Okay. So you remember the 3 words, repeat the 3 words, and then step 2, draw the face of a clock. I think instruction கூட ஒரு பெரிய வட்டம் போடுங்க. வட்டத்துக்குள்ள கடிகார மாதிரி நம்பர்லாம் எழுதுங்க. எழுதிட்டு 11 மணி 10 நிமிஷம் காமிக்கிற மாதிரி பெரிய முள்ளு சின்ன முள்ளு வரைங்க. அதுக்கப்புறம் once they have done that, then you ask them the 3 வார்த்தை சொன்னேன் என்ன வார்த்தை ஞாபகம். That's it. Okay. Now this particular tool is very good, has a good sensitivity to pick up early cognitive impairment. So again, clock drawing வந்து எப்படி இருக்கணும்னா வட்டம் ஒழுங்கா இருக்கணும், உள்ள நம்பர்ஸ் கரெக்டான பொசிஷன்ல இருக்கணும், அண்ட் சின்ன முள்ளு பெரிய முள்ளு கரெக்டான பொசிஷன் தான் போட்டுருந்தீங்க கேட்கிற டைம். So the interpretation is, if all the 3 words are recalled and there's a normal clock, the person has passed. We don't have to worry about that. Only 1 or 2 words are recalled when the clock is normal. Again, it's probably not, nothing to worry. You don't have to worry about them. But only 1 or 2 words are recalled and there's an abnormal clock, or 0 words are recalled and there's an abnormal clock, then obviously the person has failed. You need to think this person may have dementia. This doesn't confirm that there is dementia. It only kind of screens that may be dementia. Okay, there are other things which we need to do beyond this. So once this is done, the problem someone may fail this test is because of these things. One, say they have never used a pen and paper before, they will struggle drawing a clock. Okay, the substitution there are other tests. There's something called a Matchstick design test, and it just makes it a little bit too complicated to do in a busy practice. So if we have someone who's literate, who's educated, in an urban practice, I think that should be okay. Many people who come to you will be literate, so it shouldn't be a problem. Important problem is when they have poor vision and hearing impairment. So make sure they are wearing their hearing aids properly, they have their spectacles properly so that they can see what they are drawing. When they have severe anxiety, but test சொன்னாலே எல்லாருக்கும் பயம் வந்து இவங்க குவிஸ்னு சொன்ன எல்லாருக்கும் பயம் வந்துச்சு. ஐயோ இல்ல நம்ம சொல்றது கரெக்டோ தப்போ அப்படின்ட்டு. Many of us don't open our mouths. Okay, so this happens a lot when you're testing a person. So just a poor performance once doesn't mean they have a problem. They may have a problem, but it could be because of anxiety. Okay? Lack of motivation, interest. ஏதோ அவங்க கூட் பண்ணிட்டாங்க, என் பொண்ணாட்டி கூட் பண்ணிட்டாங்க, டாக்டர் பார்க்கணும்னா பக்கத்துல உட்காந்துருக்கேன். ஓகே, 7 AM நம்ம கூட்டு வச்சுட்டாங்க. ஓகே, ஏதோ பண்ண சொன்னாங்க, பண்ணேன், அரை மனசோட பண்ணிட்டா இப்போ okay, that might indicate a poor score. And there are other problems. If I have a focal neurological deficit, I have a macular degeneration, I have a kind of posterior particle atrophy or some other problem, I may not be able to draw something. Okay, so those things also come into play. So appropriate reference. So once you know someone has failed, you may want to refer them to see a neurologist, psychiatrist, or a geriatrician, depending on who is available. So again, not everyone deals with dementia. You may want to know who is kind of dealing with dementia in your neighborhood. So that's about screening for dementia. I mean, I'm sure you may have lots of questions. We'll come to that at the end. But I'm just going to move a little now, go to the next stage about managing someone with dementia. I'm just going to give you a brief overview of what can be done. Okay? Often this happens a lot. There is therapeutic nihilism about dementia. Dementia, என்ன பண்ண போறாங்க, ஒன்னும் பண்றதுக்கு இல்ல, சும்மா போய் இருக்கு டாக்டர் பார்த்து நீங்க வீட்டுல இருங்க. I have heard this so many times. Okay, now that is actually not correct. There are lots of things can be done to help someone with dementia and improve their quality of life. We'll just see what is available, what are the options that are there. So when you look at someone with dementia, these are the various ways of management. These are the various areas where we can help someone. Okay? It's not just one thing. So cognition. Cognition, our aim is not complete remission or recovery. Unlike other disorders, say like an infection where your aim is to achieve complete remission, complete recovery. In dementia, we are not looking at, it's like managing someone with diabetes or hypertension. We are looking at symptom control to an extent and slowing down the deterioration. So the options are drugs, psychosocial. Drugs, there are lots of drugs, acetylcholinesterase inhibitors. There's so much of evidence base currently available. You don't have to have much doubt about this. Okay, as long as they are being used, they are helpful in reducing the symptom load and in controlling some of the behavioral problems and in delaying the progression problems. Okay. So acetylcholinesterase inhibitors, India rendu dhaan irukku ipo. One is donepezil, other is rivastigmine. Galantamine, it's not easily available now. NMDA antagonists, we have called memantine. So these are the three drugs which we can use for someone with dementia here. Okay. And memantine Admentan brand lo varum. So there are also other brands. And then we have drugs like donepezil. Donepezil comes in brands of Aricept, Donep, okay, those kind of things. Donitas, these are some of the common brands. And rivastigmine comes as Exelon, Rivamab. Those are the brands which are available right now. So in terms of practice points, even if there is no significant improvement, if tolerated, continue and review. Okay. One improvement delay, this is a common thing. These are expensive tablets also, they're not very cheap. So they continue. Now the point is, you may not see a discernible change immediately, but what we notice is that slows down the deterioration happening otherwise without the medication. The important thing is, we'll talk about it when we come to managing behavioral and psychological symptoms. These tablets potentially reduce the emergence of behavioral and psychological symptoms in dementia. So in that way, these drugs are very, very useful. Okay. And then cognition, other non-drug treatments. There are so many treatments available. Now, cognitive stimulation therapy is something which I commonly use in our setup. This is manualized, evidence-based intervention, as good as giving medicines. And we have a manual available in Tamil. We can provide this here in Chennai. There are lots of things which are there. Again, just some evidence for this. Now, looking at ADL, the activities of daily living. So the next domain. So we address cognition. But it's the ADL. ADL, again, the goal is to maintain independence. Now, common of ADL is bathroom use பண்ண முடியல, குளிக்கிறதுக்கு கஷ்டமா இருக்கு. This is something which I commonly ask some of the students who come to me. நீங்க கடைசியா டாய்லெட் பக்கத்துல நின்னது எப்போ நீங்க when did someone assist you with passing motion? Okay, how easy it is to have someone standing next to you when you're passing motion. Okay, how easy it is for you to help you put on your undergarments. Okay? It is demeaning. Okay, you don't want someone to do that for you. Okay, but then we expect a person with dementia to just accept பண்ணிட்டு அவங்க பண்றதுக்கு கேட்டு போயிட்டு. Okay, which is a big problem. So the main thing is to give independence, to maintain their dignity, and maintain their safety. The problem is time ஆகுது சார், அவர் விட்டா அவர் ரொம்ப நேரம் பண்ணிட்டு இருக்காரு, குளிக்கிறதுக்கு பாத்ரூம் போட்டு ரொம்ப நேரம் ஆகுது, அதை போய் பண்ணி முடிச்சுட்டு வந்துடுறோம். Okay, the thing is we need to give them time. There is no other option, otherwise it's going to create problems. Now what happens is, because they don't like someone standing next to them when they're passing motion, they don't want to go to the bathroom. So what happens, they kind of retention, constipation, impaction, and then other problems வந்துரும் பின்னாடி. So when it's not needed, don't overdo things. Ask the person with dementia to do as much as they can by themselves with minimal support. வெளியில இருந்துக்கோங்க, வெளியில இருந்து give them instructions step by step, rather than going in and standing in front of them. Sorry, activities of daily living. Sorry, I should have put that there. And again, our goal is to actually slow down the deterioration as much as possible. So involving family members, they are well intentioned. Okay, the intentions are good. They want to help the person, but again, they sometimes don't know how to do it. Accessibility. I'll just explain that in a minute. Encourage the person to perform as many activities by themselves as possible. Positive risk taking. I'll give an example of positive risk taking. We had a gentleman in dementia who got lost once. வெளியில போனதுக்கான வழி தெரியல, அதனால என்ன பண்ணாங்க, வீட்டுக்குள்ளே பூட்டி வச்சிட்டாங்க. வீட்டுக்குள்ளே பூட்டி வச்ச உடனே he became dull, he became agitated, angry, கதவை போட்டு உடைக்க ஆரம்பிச்சிட்டாரு. Then it became a problem for the family. So what we did was, there are GPS trackers which are available now. They are very cheap. It's about 4,500 rupees for a GPS tracker. A page or you can attach to their clothing. And you can also water. They can go wherever they want, and we can actually track them on a Google map, on a phone. Anybody who has access can track them. Okay. So positive risk taking is, there is a risk of this gentleman being lost, but we are kind of taking a risk in sending him out, but with some protection measures in place. Okay. Or என்ன பண்ணனும், கூட யாரையும் கூட்டிட்டு போங்கனா போக மாட்டார். Okay. So this actually allowed him independence, but also keeping him safe. Okay, that's kind of positive risk taking. So things like that which we can do to help someone. So assistive technology is very similar to that. Whatever technology we can use to help someone to maintain their functions. Okay. And regular physical activity and exercise, as you know, is very important to keep them well. Arthritis, okay, they may put on their diabetes control, they become poor. All these things will happen if they don't exercise, if they don't go out of the house. Now we did a home visit. I don't know if you can see it very clearly, but anyway, this is how a person with dementia will see this place. Okay, very cluttered, no light, everything everywhere, and the report. Okay, that was the complaint. Okay, no wonder he is falling. Anybody will fall in that situation. Okay, so design and environment for dementia is so important. This is our inpatient unit in Salem. As you can see, it's specifically designed for someone with dementia. Okay. So you have colored doors, and then you have signposts for signage for corridors. And you have uncluttered space. There is a lot of space to walk around, and everything is clear. You can see where everything is. It's bright. Okay. Is another view of the same place. So decluttering, removal of hazard. Again, another thing you should note, there are no rugs. Okay, another common thing which in the bathroom is okay. So those kind of things, non-slip floors, non-slip, basic things like linoleum covering portal will actually prevent falls. And the non-slip linoleum covers which you can just apply. This are costly tiles. It's not very expensive to do. So things like that which are available here right now in our country. Signage, as I said, and assistance within the toilet. So it's actually a picture of the toilet in our center. We'll have grab bars which they can use to sit up, to get down. Okay, those kind of things which will help someone with dementia to be independent. Put these things in place. You don't have to go inside, so they can maintain their independence and dignity. Okay, moving on to the next topic, which is behavioral and psychological symptoms in dementia, shortly PTSD. So there are many things which people with dementia will have, and most, of course, to a general practitioner, the presentation of someone with dementia will be different, but to a psychiatrist, almost 90% of people with dementia come to us with behavioral problems. That's why they are referred to us. So they may have, delusions, hallucinations, and things like that, sexual disinhibition, anxiety, depression, sleep disturbance, eating problems, Okay, they may have sleeplessness. So there can be anything. So whole array of symptoms which someone with dementia may present with. So the goals in managing some behavioral psychological symptoms is prevention. If we can prevent BPSD from emerging, fantastic. Okay. Now, some of the things which we did for protecting their activities of daily living, protecting, maintaining their dignity and independence will actually prevent behavioral problems from emerging. Okay. One of the common things when there are reflective surfaces, கண்ணாடி போடுறாங்க இல்ல வந்து இந்த மாதிரி ரிஃப்ளெக்டிவ் சர்ஃபேஸஸ் இருந்தா என்ன ஆகுனாக்க when they see a reflection of themselves, what happens in moderate to severe stage of dementia, the area of the brain which is responsible for recognizing faces, that when that gets impacted, they see that reflection, they think somebody is there. Okay, we have had a patient who would kind of கண்ணாலே பேசிட்டு இருப்பாங்க, கண்ணாடிக்கு முன்னாடி பேசிட்டே இருப்பாரு. Okay, he gets very agitated. Sometimes he gets very annoyed. Someone is there in the room. Okay, and then he gets very angry, upset, agitated, and all that. So simply, that's all. We just advise the family to put a screen, remove the mirror whenever it's not needed, and put a paper on top of it. Just stick it up, and that's it. The reflection is not there. He is not seeing it, then he is fine. Okay, so that happens because of perceptual problem. He is not able to the cognitive impairment primarily, but cognitive impairment leading to behavioral problem later on. Okay, இந்த மாதிரி தனியால் தன்னால பேசிட்டு இருக்காரு, தன்னால இது பார்த்து பேசிட்டு இருக்காரு, நம்ம அவங்களுக்கு ஆன்டிசைகாட்டிக் கொடுத்தோம்னா ஹேலோபரேடால் கொடுத்தோம்னா it's not going to, they are not going to respond to that. Only thing will happen, they'll have side effects. Okay, so that's very important. Again, early identification of symptoms emerge ஆகும்போதே சரியா தூங்க மாட்டேங்கிறாங்க, ஒரு வாரத்தை they come to us, immediately addressing it is very important. Again, time limited treatments. இவங்களுக்கு வந்து some of these drugs, they start for one problem and they get continued for months together, which will cause problems. Antipsychotics use in people with dementia increases the risk of stroke and death. Okay, there are lots of community studies which have shown that long-term use of antipsychotics in people with dementia definitely increases their problem. Yes, sir. Yeah. Cerebrovascular, cardiovascular diseases and death. Okay, so common. Adanaல, we shouldn't be prescribing antipsychotics in the longer term for people with dementia. Okay. So look for physical illnesses. Common, almost 80% of people with behavioral symptoms have a physical illness. Okay, we need to screen for physical problems. Common things: infection, toothache. We had a patient who refused to eat. Crush. Okay, so sottapallu, so common. They are not able to eat. They will not be able to say because they lost the ability to communicate. Pallu velikudhu, vaai velikudhu solla maatanga. All we need to discern by their behavior. We know they are not eating. Vaaya tharakka maatanga, vaaya kitta kondu pola kattranga. Okay, it means there is something wrong with their mouth. Examine their mouth. Okay, so those things are very, very important. Look for a physical illness. Look for pain. Pain is again so common. People with dementia will not be able to report that they are in pain. There's a very interesting study done in the UK where they compared use of haloperidol and paracetamol. Okay, direct randomized controlled trial in someone with dementia and who is agitated. Okay, and they found surprising report is paracetamol has a better outcome than haloperidol. Okay, 1 gram paracetamol 4 times a day did better than haloperidol. Sorry? Pain, unreported pain. Majority of people with advanced dementia have pain which makes them agitated. Pain control, the symptoms get better. Okay. So pain is so important. So many of us, as we get older, we all get pain. People with dementia are spending a lot of time not doing anything. Okay, they're not exercising, they're not doing anything. They will be in pain. Okay, we just have to. In fact, all the patients we see, we routinely start them on paracetamol to help them. Because pain and agitation will definitely come down. And then look for early referrals to specialists and biopsychosocial intervention. There are lots of interventions which we can do, which again, I'm not going into too much detail today because it's just about giving an introduction. Physical health, maintaining someone with dementia, maintaining physical health, someone with dementia is so important. Again, the goal is to prevent new issues, new complications, remission of any treatable problem, and reasonable control of existing health problems. So those are our goals. Being alert and aware. So diabetes, They may either overdose, they may not take their medication, so it need to be very aware of what might happen to this person. Regular health visits, regular monitoring, avoid hospitalization if possible. If you can avoid hospitalization for someone with dementia, that's the best outcome. Okay. Facilitate early discharge if they are admitted to the hospital. Polypharmacy, again, multiple drugs should be avoided. Okay, particularly. So as I said, 80% of the time, the behavioral problems are because of physical problems. So uncontrolled diabetes, infections, pain, as I said, urinary infections, constipation. Constipation is so common in elderly. Many of them will not be able to say that it's just agitated, night all this will become a problem. So we need to be kind of proactively looking for these things. Then the next important area we need to focus is caregiver issues. India, 90%, more than 90% of the care is provided at home, not in care homes. And family members are the main caregivers. So caregiver burden is such an important thing, particularly when you're talking about physical aspects to looking after someone. Okay, so physical aspects. And then there are psychological and emotional aspects. கிட்டக்கு போனா எங்களை யாருன்னே தெரியல, எங்களை திட்டுறாங்க, எங்களை அடிக்கிறாங்க. ஓகே, இவருக்கு எதுக்கு நான் பண்ணணும்? Okay, so thanks கூட சொல்ல மாட்டேங்கிறாங்க. And then the social isolation for caregivers of dementia is so kind of common, unfortunately. So dementia அவர்கிட்ட வீட்டுக்கு யாருமே வர மாட்டாங்க. ஒரு பையனோ பொண்ணோ பார்த்துப்பாங்க. The rest of the family will just stay away. They don't come. Only thing they will do is நீ சரியா பார்த்துக்க மாட்டீங்களா, நீ வந்து சரியா இந்த மாதிரி பண்ணிருக்கலாம்ல, நீ அந்த டாக்டர் போயிருக்கலாம்ல. That will be the kind of complaints that many caregivers will do. So social issues, கல்யாணத்துக்கு போக முடியாது, ஏதாவது ஃபங்க்ஷனா போக முடியாது, those kind of things happen. And there's financial burden. It's a huge financial drain. There's a study from NIMHANS in 2013. It costs about 50,000 rupees to look after the person with dementia per year. This was 2013. It's a gross underestimate. Okay, it's much higher. So there are lots of challenges, lots of needs that the caregivers have, which again, the goal of managing is prevention of caregiver burden, early identification if there is, and provide interventions for complete remission. Unlike dementia, caregiver burden, we can provide complete remission. Cognitive symptoms, caregiver. So again, information and education. Give them a lot of information. Signposting. The help கிடைக்குதுன்னு சொல்லலாம். Like we can give them specific training. எப்படி நீங்க சாப்பாடு கொடுக்கலாம், எப்படி அவங்க குளிப்பாட்டலாம், எப்படி அவங்களுக்கு டயப்பர் மாத்தலாம். Those kind of simple things which you can give. Specific caregiver interventions இருக்கு. அவங்க ரொம்ப burdened இருக்காங்க, depressed இருக்காங்கன்னா அதுக்கு we can give them intervention. There is a support group for caregivers of person with dementia in Chennai, which meets very regularly. They meet online because of the pandemic. They also have started meeting in person nowadays. So you can actually refer caregivers to these support groups. And then screen for any psychological problems like depression, anxiety, and other things. Okay. So the last topic I'm going to talk about is end of life care and dementia, because this is where I think as a family physician, you will play a very big role. So as you know, why we talk about palliative care? Palliative care is commonly associated with cancer. But I think in dementia, any chronic degenerative condition, palliative care becomes important. Because we don't have a disease modifying cure as yet. Maybe in the next 20 years we may have, but right now we don't have. And there are growing numbers of people with dementia. Right now we are talking about almost 50 lakh population with dementia. So 50 lakh in India. You bring all the person with dementia into Chennai, half of Chennai will be dementia. Okay. So that's how many the numbers are. And that is going to go to 1 crore in the next 10 years. Okay. So the whole of Chennai, you bring all people with dementia into Chennai, the whole of Chennai will have dementia. Okay. So that is the number of people with dementia we're talking about in India. And the median survival after diagnosis is about 3 to 7 years. That's because in India it's even less because we diagnose late. Okay. And the person with dementia are being exposed to non-beneficial interventions like artificial nutrition, peg tube water, NG tube feeding. These are all non-essential, harmful interventions for people with dementia. Okay. They get hospitalized very frequently. They get unnecessary diagnostics done, which is probably not helpful in end of life care. So what are the predictors of high morbidity and mortality? Higher age of diagnosis. The older the person to diagnose, the more likely they are going to die sooner. And then looking at their low functional status at the time of diagnosis. And then when they have pneumonia, so what is of pneumonia when they have 6-month mortality rate is almost half. Okay, 50% of people who have had, so someone with advanced dementia has a pneumonia. There's only 50% chance that they will live the next 6 months. Okay, there's an indicator this person needs palliative. Again, if they have a food disorder, if they have an eating problem, it comes to about a third. Okay. And then good palliative care begins at the time of diagnosis. Start thinking about it right now. So when do we have to provide earlier the better? And there is advancing illness when they become non-moving. They're kind of spending most of the time in the bed or in the wheelchair. And they've lost meaningful conversation. They're dependent on others for everything. Bathroom, feeding, everything. And there's 10% or more of weight loss. Okay? And there is recurrent infections, pressure source. These are the things which indicate, again, so as I said, hip fracture. Okay? And these are indicator factors that this person needs palliative care. And there's a need for feeding. They are not able to eat by themselves. So common symptoms, pain, agitation, shortness of breath, aspiration, and pressure ulcers. There's a thing we need to look for when you have someone with advanced dementia. So common cause of death, pneumonia, aspiration related, or could be community acquired pneumonia. And then cardiac events, they may have, because they are inactive, they may have premorbid cardiac illness, cerebrovascular events, and other infections. These are common cause of death in someone with dementia. So palliative, the focus is on providing comfort, improving the quality of life, and providing support for the caregivers. And the caregivers will be ridden with care. What should we do? Okay, that will be a very problematic thing. So what are the areas that we can focus on? So nutrition is so important. We need to talk about that. Infections, repeated infections. Okay, how appropriate is to treat someone, give them lots of medicines. What about pain? What about mood and behavior and supporting? These are the various domains we need to look into when looking at palliative care. Nutrition, refusal of food. Now that can be due to a variety of reasons. If it is a reversible thing like oral pain or ulcer or things like that, you can treat it and then they can start eating. Now what happens in advanced dementia, they just don't recognize something as food. So okay, we have a patient like that. So what we do is we pick up, we break it and then put it on their lips. Okay, nalla sambar and the flavor, it should be really flavorful. Just dip it in sambar and put it on their lip. They lick it and then they take it. Okay, in a while they will not even open their mouth. So the more you force, the more they will resist. Okay, so if it is that, it's relatively easy to manage. You give them, you show them, you give them a taste of it, and then they start eating. Okay. Now, in some cases, what happens, they will start developing aspiration problems. They'll kind of choke, dyspraxia of mastication. So the coordination point, so they will not be able to chew and swallow, everything operating in synchrony. So that synchrony is lost. They'll swallow prematurely and then they'll start aspirating. They'll start coughing. Okay. So common question we ask is, then it indicates that they have a problem eating. The dementia is advancing. We need to think about how to feed them. They may have problems with solids or liquids. Okay. Sometimes coffee or sometimes solids out of more than. So what are the things you do is, if it's easy, solids, make it into smaller pieces. Give them soft food. Don't give them roti, chapati, and all those things. Soft, okay. Give them soft things, mashed things. Okay. Give them in a semi-solid consistency. Mixi ladichi kodunga and kanji mari kodunga, things like that. Whereas if they have aspiration for liquids, then we say thicken the liquid. Okay. There is a powder called thicket or powder. Jelly mari. Then they can eat water. Okay. So they don't get dehydrated. Okay. So things like that which we can do to prevent aspiration. So forced inappropriate feeding results in aspiration. So some surprising. Okay. Clear aspiration. They will start repeated cough, aspiration, and so often that results in hospital admissions. So hospital, the first thing is NG tube, okay, peg feeding, those kind of things happen. And there's no evidence to support these measures of supported feeding in people with dementia. In fact, they cause more harm. They cause repeated infections, ear infections. Okay, they themselves increase the risk of aspiration. Now, on a patient dementia will try to remove the NG tube. So again, So kaiyagatti potane, the person becomes even more agitated. Kaiyagatti potana. They won't be able to say that they are kaiyagatti potache. They will show it in their kicking, shouting, moaning, okay, tungumatanga, all the things. So what we do, we give them haloperidol. Easy, give them haloperidol. Then they start developing pressure sores, nadakave maatengiranga, pressure sores, quick death. We are only kind of sending them, giving them tickets. Okay. So they cause more harm. Okay. So it's very, very important. We need to remember this. So what can we do? Assess swallowing. Speech and language therapists can help us do that. They can assess how many consistent the aspiration of it, we can check that. Educate the family member. That's very, very important. Okay. And not nominated representative. Mental health actually have a nominated representative who can actually involve them in all decisions. Otherwise, they may say, நீங்க ஏன் ட்ரீட்மெண்ட் கொடுக்கல, ஏன் உங்களுக்கு ஃபீடிங் பண்ணல, நீங்க டியூப் போட்டிருக்கலாம், நீங்க சொன்னா நான் போட்டு சொல்லிருப்பேன். Those kind of things. It's just important to have this conversation. Optimal hand feeding. Spoon kayala kudukkuறது sometimes easy for people in our culture. So it's easy to feed them with hands, upright position, always in an upright position. And preferred foods, அவங்களுக்கு என்ன மாதிரி ஃபுட் பிடிக்கும், முன்னாடி அவங்க என்ன சாப்பிட்டுருந்தாங்க, okay, and then right consistency, strong flavors. What happens in dementia is as the illness, I think this is common as we grow older, sense of smell comes down, sense of taste comes down. So only thing they will kind of be able to perceive strong flavors, very strong flavors, and sweeter. So often what we tell is, நீங்க சாப்பாட்டுல சக்கரை கலந்து கொடுங்க, வெள்ளை சக்கரை போட்டு கொடுங்க, கலந்துட்டு you can give it. So diabetes அப்போ diabetes இருக்கதான் செய்யுது, அதுக்கு என்ன பண்ணுங்க, okay, ஒண்ணுமே சாப்பிடாம give them something, okay. So you need to kind of take a balanced view of things. So that's what we need to do. Smaller amounts and frequent reminders to swallow. Infections, common, very common. To treat or not to treat. Okay, as a physician, you will face this a lot. Focuses on comfort. Repeated IV antibiotics, repeated admission to hospitals for someone with pneumonia is not going to be helpful. Okay, so once, twice, it's okay. The third time, if it happens, you may want to think about this is the right action. Okay, maybe give them oral antibiotics, keep them at home rather than admit them to a hospital. Okay, and things like that. So consider very carefully. You need to balance many things and discuss with the family. Again, appropriate use of medicines. Again, you need to think about whether some medicines are still being useful. ரொம்ப வருஷத்துக்கு முன்னாடி ஆரம்பிச்ச ஏதாவது ஒரு வைட்டமின்ஸ் will still be continued. Is it necessary? You may want to stop it. அவங்க சாப்பிட முடியல, பொடிச்சு நாங்க தண்ணியில கரைச்சி கொடுத்துட்டு இருக்கோம் அப்படின்பாங்க. Okay, so you need to think about whether this is something needed for that particular patient. Okay, pain we already talked about, very common. But look for indirect symptoms of pain: agitation, being more withdrawn, சரியா தூங்க மாட்டேங்கிறாங்க, சரியா சாப்பிட மாட்டேங்கிறாங்க. Those may be indicators of pain. Move பண்ணும்போது கத்துறாங்க, டாய்லெட் டயப்பர் மாற்றும் போது கத்துறாங்க. Those things are all we are looking at a possible pain as a problem. So paracetamol used quite freely. Tramadol comes with a problem, constipation, confusion, சில சமயம் problem வருது, but it's severe pain, you may want to use it. Morphine, very advanced dementia. Okay. Non-pharmacological interventions, fermentation, hot, cold application, okay, engaging them in music, engage them in activities, or just keep playing. So they're in the bed. Imagine laying in bed 24/7 with no stimulus going on around. Okay, so having some music in the background, the kind of music they like, okay, not we like. Okay, so we need to actually make sure that they kind of we put them things, sensory stimulation as much as possible. Okay, we already talked about that. I think I've taken a lot of time. So I will conclude with this. We see more dementia in our clinics now. It's possible to screen for dementia in a busy clinic. Managing physical health issues is very, very important. When it improve their overall condition. While there is no cure for dementia, there can be a lot that can be done to help them and improve their quality of life. There are medicines and non-drug interventions available which can slow the disease process and improve the quality of life. Supporting caregiver is very, very important. Networking and support and signposting is very essential. So, dementia in a single practitioner, it's difficult to manage. Dementia has to be managed by a team. Okay, that's very, very important. So I want you to make a guess as to who is the person with dementia here. The man or the woman? Okay, you're right. But sometimes it's difficult to guess. Okay. So, yeah. The husband and wife sitting together. This is my wonderful team that I work. This is my grandfather who passed away this year with dementia. So I'm just kind of enjoying life in the lake. May not be unpleasant and boring and difficult, but you still have a good life with dementia, like my grandfather. Thank you.
Thank you, sir. Can I request Dr. Selvan sir, our Financial Secretary of IMA Chennai Metro Branch, to honor our chief? Thank you, sir. Can I now introduce